bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard. I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to talk about personality and risk for substance abuse, the background, content, and evidence base for the Preventure program for adolescent substance abuse prevention. And it's a great pleasure to welcome back Dr. Sherry Stewart to the CAFC Presents stage. Sherry joined us about a year ago, along with Dr. Chris Weckerly, who often joins us on these types of presentations, where they were talking about the maltreatment and adolescent pathways research study. So it's great to welcome her back. And particularly with the interest in this topic, obvious by the registration that we have for this one, but mental health and addictions for the pediatric health centers and the acute care community across the country, certainly impacted by mental health and addictions. We do have a presentation at our upcoming conference, the preliminary program, to be coming out in the next couple of weeks. But we will be having a session on public health issues such as the opioid crisis and legalization of marijuana and all of those sorts of substance abuse related issues that affect children and youth and subsequently often affect the pediatric health centers across the country. So it's my pleasure to introduce Dr. Sherry Stewart, who is a clinical psychologist and a CIHR research chair in addictions and mental health. And she's also a professor in the departments of psychiatry, psychology, and neuroscience, and community health and epidemiology at Dalhousie University in Nova Scotia. Dr. Stewart is interested in applying the findings of her research to provide evidence to guide clinical interventions for individuals living with different emotional and addictive disorders. And Dr. Stewart, along with Dr. Patricia Conrad, co-developed the school-based substance abuse prevention program Preventure, which we're going to hear about today, which is now used in several countries around the world. So we're very excited to hear more about this program. So it's my pleasure to hand the virtual podium over to you, Dr. Sherry Stewart.
Thanks very much, Doug. It's really a pleasure to be back again. And I wanted to just acknowledge Chris Weckerly for suggesting that we do this, and I'm really glad that there's been such an interest today in hearing about the Preventure program. So the Preventure program is a targeted school-based program for preventing adolescent substance abuse. And it's a program that I say is targeted because, unlike most school-based programs which are universal, in other words, all students are exposed to the program, this program is targeted towards kids that are already at high risk, and we identify their high risk by virtue of their personality characteristics. So I'll be talking about starting off with the theoretical background behind the Preventure program, and then I'll walk us through what is the evidence for the theory behind the program. We'll take a look at the program itself, and we'll look at quite a bit of the time will be spent on the evidence base that we've accumulated on its effectiveness, both as an early intervention program with kids that are already using and for delaying onset of use for those kids that haven't started yet when we've used the program a bit earlier. So we'll take a look at what substances is it effective for. We'll take a look at who can deliver the program, and do we lose effectiveness when we have school personnel deliver the program, those kinds of more practical issues. So let's just get right into the theoretical background. So around the year 2000, based on a bunch of lab-based research that we'd done coming out of Bob Peel's lab. So Patricia Conrad and I were graduate students in Bob Peel's lab at McGill in the late 80s and early 90s. And based on a lot of different research that we were doing, we were coming to some conclusions that there really are different pathways to people developing problems with addictions, and that those pathways really matter in terms of how we want to treat people for addiction and how we want to prevent addiction problems from developing. So we developed a motivational model of risk for substance abuse that talked about 4 different theorized brain motivational systems that when there's sort of a dysfunction in any of those systems, it would lead to a specific vulnerability profile, vulnerability to both developing addiction problems on particular drugs and also comorbid mental health problems, so vulnerability for comorbid mental health problems. So we're really talking about sort of common vulnerability factors, and that these vulnerability profiles would be associated with different motives for substance use. So that one pathway to substance use might be people who are using for one particular reason, whereas another pathway an individual might be using for quite a different reason, and they'd end up with the common problem that we call an addiction or a substance use problem or disorder, but they get there from very different routes. And also that these different vulnerability profiles would show differential sensitivity to particular drug reinforcement effects. So we've done quite a bit of research on that in the lab, for example, showing that certain people are more vulnerable to the anti-anxiety or anxiolytic effects of certain drugs, and other people are more susceptible or more vulnerable to the stimulating, rewarding, stimulating effects of drugs, and that both people could end up with an addiction, but by very different pathways. So what are these 4 different vulnerability profiles, and how do they present in terms of personality? Well, 2 of those theorized vulnerability factors are more externalizing kinds of acting out types of personality characteristics. So sensation seekers, individuals that prefer novel, intense kinds of activities, impulsive people that have difficulty delaying behavior in face of immediate reward and not thinking through or not being able to consider the longer-term consequences of their behavior. And then 2 that are more internalizing types of personality traits, so anxiety sensitivity. So this refers to something more than just being an anxious person, although it's correlated with being an anxious person. But an anxiety sensitive person is somebody who's very sensitive to their sensations of anxiety. So they fear the arousal-related symptoms that accompany being in an anxious state. And hopeless individuals, so individuals that have sort of a negative set in terms of perceptions of themselves and of their futures. And these 4 types of individuals are said in our theory to be susceptible to using drugs for different reasons. So the more externalizing traits, sensation seekers, are said to use drugs to enhance positive affect. Impulsive individuals, because they have difficulties with response inhibition, so they're engaged in engaging in behaviors that are immediately reinforcing, like substance use. And both the anxiety sensitive and hopeless individuals are said to be more vulnerable to using drugs to regulate negative affect, with the anxiety sensitive people in particular vulnerable to using drugs that have more anxiolytic or anxiety reducing effects, and the hopeless individuals more susceptible to drugs that have more numbing or dysphoria reducing properties. And these can be measured by a questionnaire we developed called the SERPS, or the Substance Use Risk Profile Scale, and I'll talk a little bit about some results with the SERPS shortly. But this model here just kind of walks us through these different personality vulnerability factors and the brain or cognitive or motivational systems that underlie each of those traits, and how those set them up for being more susceptible to using particular types of drugs. So impulsive individuals, due to their poor response inhibition and their underactivation of prefrontal cortical circuits that control behavioral planning and organization of behavior, that they're more susceptible to drugs that have immediate reinforcing properties like the stimulant drugs. Sensation seeker, and in turn also that each of these personality traits is vulnerable to particular co-occurring mental health disorders. So impulsive children being more vulnerable to developing externalizing problems like ADHD, conduct disorder, those types of problems. The sensation seekers having a particular sensitivity to reward, they are also more likely to be vulnerable to stimulant drugs, alcohol in particular, and also cannabis. But they don't seem to have a whole lot of comorbid psychopathology. It's more the impulsive individuals that seem to be more vulnerable to externalizing mental health disorders. In terms of hopelessness and anxiety sensitivity, they do share a common motivational profile in terms of being negative thinkers and being very reactive to stress. But the anxiety-sensitive individuals on top of that tend to be very over-aroused and very sensitive to threats in their environment and to activation of the fear system. And so they're more vulnerable to abusing sedative types of drugs. The anxiety-sensitive individuals to anxiolytics and the hopeless individuals to opiates in particular. And each of them is also vulnerable to the development of particular mental health disorders, mood disorders for the hopeless individuals, and anxiety disorders for the anxiety-sensitive individuals. So that's just walking you through the model. What about evidence? Well, the first evidence that we garnered for this, I'm not going to spend a lot of time on it today because we really want to focus in on the youth, but just when we first started, we actually were working with adults, and we tested in 293 community-recruited women who were abusing or dependent on substances. We tested whether these different personality profiles would help us understand them being drawn to particular drugs, so particular drugs of choice and the ones that they're more likely to become dependent on, as well as their comorbid psychopathology. And I'll just show you briefly some results that we got from that study that we published in Psychology of Addictive Behaviors in 2000. First of all, in that sample of 293 women, through cluster analysis, we were able to identify 5 different personality vulnerability profiles, well 4, and then a group that didn't seem to have a lot of personality vulnerability. In fact, just out of interest, those women tended to have partners who were substance abusers. So it wasn't so much through their personality that they seemed to develop substance abuse problems, but through more environmental factors. So it was about equal numbers of women falling in these 5 groups. And we took a look at how many of in each cluster reported exclusive dependence on one particular class of drug. And as you can see here, it's really the sensation seekers that are having problems with alcohol in particular. Consistent with our theory, the anxiety-sensitive women tended to be more likely to be dependent on anxiolytic drugs like the benzodiazepines. It was the impulsive individuals who are more likely to be dependent on stimulant drugs, so cocaine, for example. And although we had fairly low rates of opiate analgesic dependence at that time when we did the study in the 90s, we did find that there was still, even with that low rate, there was still a significant effect where the hopeless individuals were the ones that were more likely to be dependent on opiate analgesics. What about mental health disorders? Again, we see a lot of specificity of the particular types of mental health problems that each personality type was vulnerable to. So these are giving odds ratios relative to all the other personality types. So you can see the anxiety-sensitive people are 2.1 times more likely to be diagnosed with simple phobia, and about 6 times more likely to have a disorder, somatization in the DSM-3R, that's really like a lot of physical health complaints that don't have a lot of physical cause. And the hopeless individuals were more likely to have depression and also agoraphobia, as well as social phobia. The impulsive individuals were more likely to be diagnosed with the one externalizing disorder we looked at for adults, antisocial personality disorder. And with the sensation seekers, they tended to have more problems with substances, but not so much mental health problems. Same with the low personality risk group. So we do see some validation in people that already have substance use disorders, but what about youth? So we really wanted to go on to look at validating the model in youth and develop interventions for use and prevention and early intervention of alcohol, drug abuse in high-risk adolescents. So first, validation of the model. So just why focus on youth? I think probably I don't need to do a lot of convincing of the audience here, but we do have global trends indicating earlier age of onset of substance use in youth, and concerns about earlier age of onset because that seems to be associated with greater risk of later addiction. And when adolescents present with substance use disorders, it tends to be a more complicated picture clinically than when adults do. We also see global trends indicating increasing rates of binge drinking in young people, and that we know that alcohol is a leading cause of death for 15 to 29-year-olds around the world. So it's very highly associated with the leading cause, which is the injuries and accidental injuries. So I've mentioned that substance use disorders are quite complex. They're more severe and complex when they present in adolescence. And that adolescents, when they're exposed to substances, they have a higher risk of developing a substance use disorder and associated mental health problems than do adults. Higher rates of substance use disorder in those that are exposed. So in terms of validating the model, first of all, we wanted to see if each of this was a study that we did with one of Patricia Conrad's former graduate students, Patricia Wojcik. We did both studies of both adolescents and young adults. What we were able to show is that each of the personality risk variables was associated with at least one, if not multiple, drinking and drug use variables. So all 4 of the personality vulnerability factors were associated with, this is in a very large sample of young people, and you can see each one of them is associated with alcohol problems. And hopelessness, impulsivity, and sensation seeking were each associated with greater quantities and frequencies of use, binge drinking, and other drug use as assessed on the risky behavior questionnaire. In terms of motivations for use, we also see some differences here. So the hopeless and anxiety-sensitive individuals tended to use to cope with negative emotions and to fit in with peers, so that's conformity motive. And we also see that the impulsive individuals are using for a lot of different reasons: to cope, to socialize, to enhance positive mood states, to fit in. So they have quite an undifferentiated profile. They use for pretty much any reason. And we see quite a different pattern amongst the sensation seekers, where they use more to improve positive mood states, so for the rush and the high, but they also use to socialize with peers, being that they're more extroverted types of young people. We also looked at the predictive validity of the scales in another study with Marvin Crank at UBC Okanagan, and we were able to show over 1 year that we see each of the personality factors, except for anxiety sensitivity, being related to increasing use or problems with substances. So you can see for hopelessness, we have increased risk for a variety of different drugs, as well as alcohol and problems with substances. We're a bit surprised about the anxiety sensitivity finding, and we're still looking into that. We think there may be a developmental window where anxiety sensitivity is more protective because the kids aren't going out with their friends. They're more socially reclusive, and then it becomes a risk factor at another stage. But this is something we're looking into presently. In terms of the development of personality-matched preventative interventions, the beginning of Preventure, we developed these in a Canadian study, and we started off by developing them first for sensation seekers, anxiety-sensitive, and hopeless young people, and we added the impulsive interventions later. We had developed these interventions with substance-abusing adults, and we adapted them for the use in adolescents. And we also did some qualitative interviews with kids from each of those personality types to get scenarios that we would use in the manuals to make the scenarios very realistic to their personal experiences. Each of the interventions, so we developed a specific intervention for each of the personality types. What they have in common is a common structure. So they all start off with a motivational component, then move on to psychoeducation, then to a behavioral component, and then finally they're taught some cognitive skills. So I'm going to walk through that with some examples. So common to all of the interventions is in the motivational component at the beginning that students do some goal setting. So they think about their own personal goals, and this is referred to throughout the intervention. So they look at how behaviors that they may select may work towards their goals and how particular behaviors may interfere with their goals. So this is a good one for taking a look at how substance use may interfere with somebody's longer-term goals. For the psychoeducational component, we look at this is educating people, young people, about their personality. So it's presented like what is good about your personality, but also what are some troubles that your personality can get you into. And we look at particular ways of coping that that particular personality is more susceptible to. So for example, with an anxiety-sensitive individual, they're more susceptible to avoiding as a way of coping, of depending too much on other people, of using distraction as a way of coping, which might work in the short term but gets them in trouble in the long term. We consider alcohol and other drugs for each of the personality types. So, for example, they're shown to see the anxiety-sensitive people are shown how alcohol and other drugs, they explore how those are similar to avoidance and distraction in terms of being reinforcing in the short term but getting you into more trouble in the long term. And they identify, the way they do this is not through so much didactic, it's more exploratory. So they have scenarios talking about an adolescent with their personality vulnerability, and they talk about the ways that that person's coping in that scenario. And then they explore a recent situation for themselves, and they identify the ways that they were coping. And each time they share with the group. So there's a lot of active participation in the groups. Then they move on to a behavioral component where they do some decisional balancing. So they think about a recent episode and they think about particular actions that they took or could have taken and compare it to another action that they might take. And they think through the short-term and long-term positive and negative consequences of each particular behavior. Once again, they do it with respect to a scenario first that's presented for young people with that similar vulnerability characteristic, and then they do it for themselves. So this is an example of the exercise that they do in their workbooks. So they're thinking through, and by thinking through the positive short-term consequences, for example, of substance use, it helps them, it helps for the validation of why are they attracted to substances, but it also helps them take a look at in terms of longer-term consequences, and often finding that there's many negative consequences to a behavior that might be reinforcing in the short term. And then they can look at other behaviors that might achieve those short-term positive consequences but might not have those longer-term negative consequences. So that's sort of the point of that exercise. Then in terms of the cognitive component, they're taught about hot thoughts. And hot thoughts are thoughts that lead you to feel even more whatever that personality vulnerability factor is. So for sensation seekers, it might be being wound up. And for the anxiety-sensitive group, for feeling even more anxious in that particular situation. They're taught to take a look at a recent situation that caused trouble, the physical sensations that they experienced, the thoughts that they were having, and the actions that they took. And hot thoughts, they're taught, are the ones that led them to behave in certain ways, so the ones that are most closely linked to the actions that they took in that situation. So this helps them identify that there's particular components that can be broken down and that they can really target in on thoughts that they're having in a situation that further escalate the difficulty of a particular situation and lead them to get involved in actions that may not be the best choices. And they're taught how to challenge specific hot thoughts. So for each of the groups, we identify particular types of hot thoughts that they're most susceptible to, and ways to challenge that way of thinking. And they do some exercises in the groups around that and share, so they can learn from each other's challenging as well. And for kids that are having difficulty challenging, the group can be very helpful in helping them find other ways of thinking about things. So the proof of concept study was one that, this is what we often call the Canadian trial. So this was our first trial of doing the Preventure program in high schools. Now we did this as a 2-session intervention with close to 300 high school students who are aged 14 to 18 in grades 9 through 12. And we did this in Vancouver and in rural Nova Scotia. This is really as an early intervention because the kids had to already be drinking alcohol to be eligible, and they had to show elevations in personality risk in a school-wide screening. So everybody in the school took part in the screening. Those who were already drinking and who showed elevations on the personality risk were invited to participate. As I mentioned, we just did the first 3 characteristics, and we've since developed an impulsivity management intervention as well. And students were randomly assigned to either the intervention that matched with their personality characteristic, or they were in a no intervention control. And we assessed the outcome at 4 months post-intervention. I mentioned there were 2 20-minute sessions, 90-minute sessions. We ran the groups in single gender. We have since given up that practice and do them in mixed gender, but we started with single gender. And we had trained facilitators, co-facilitators who were people actually who, so here in Nova Scotia, we had people from the Choices program. So these were counselors that were already working with adolescents with substance use problems. And we used a stringent intent to treat analysis. So this means that the people who started off, if they dropped out, we just assumed the worst about them and carried forward their last values in our analysis. So here's some of the outcomes. So this is collapsed across personality type. What you see, here's what's happening in the no intervention group. We're dividing everybody at baseline. Everybody's either a non-binge drinker or they're a binge drinker because they had to be a drinker to get into the study. And this is just what happens naturally. So some of the kids stop drinking naturally, and maybe there's a reduction at that time of year in binge drinking. But what we see is with the intervention group, we're getting a much greater improvement in the number of kids that are abstinent and a greater reduction in binge drinking in those that got the intervention. Interestingly, we hadn't hypothesized this, but what we were seeing is that the interventions are working slightly differently. So for sensation seekers, they're the ones that are getting the reduction in binge drinking status. So without intervention, this is the control kids post-treatment, they're the ones that are really likely to be binge drinking, the sensation seekers. But with the intervention, they're much less likely to be binge drinking. With the anxiety sensitive and hopeless kids, they were more likely to be quitting drinking as a function of our intervention. And then in terms of intervention by time effects on the absence of problem drinking symptoms, we can see that the AS intervention and the hopeless intervention are increasing the number of kids that are not having problem drinking symptoms. We'd analyze it that way just because it's a community group rather than looking at cutoffs for diagnoses for alcohol problems because there weren't that many in the sample that were meeting diagnostic criteria, for example. And the kids really liked it too, so they thought that the scenarios and pictures were realistic because they came from real kids' stories. They talked about, this was at the follow-up 4 months later. They were telling us things that they learned in the intervention, which was really encouraging. They liked the group format, so they liked understanding what their personality characteristics were, and also kids would give us feedback that they liked knowing they weren't alone, being in the group with other kids really was helpful for them. So we see that the AS management is leading to abstinence and reduction of drinking problems. So is the hopelessness management intervention, and the sensation seekers are reducing in their binge drinking. So it does seem to be a promising strategy. So where have we gone since that initial proof of concept Canadian study? Well, Tricia Conrad moved off to the UK, and I'm going to be presenting her work for the next little bit, and then I'll come back to my work. So she did, when she went to the UK, she was living in London at the Institute, she's working at the Institute of Psychiatry, and she got a nice grant to do a randomized control trial with younger adolescents. So the median age was 14. Remember, that was the starting age for our last study. And participants either received a personality-targeted intervention or no intervention, and she collected outcome data for a longer period than we did with our initial proof of concept study. So 6 months, 12 months, 18, and 24 months, and again used stringent intent to treat. Now I'll just mention all 4 personality groups were targeted in this intervention. So can we delay growth in drinking and binge drinking when we start earlier? And I think what I'll show you here is some results that suggest indeed we can. So again, the sensation seekers, they are the ones that are really escalating in their binge drinking over time without an intervention. Whereas if you see a sensation seeker starting off similarly, but we're delaying the growth in the naturally occurring growth in their binge drink, in the proportion of them that are binge drinking. So it's really more of a preventative intervention when you go into younger adolescents. What about effects on drinking outcomes being durable? Well, I'll show you one result here that suggests indeed they can be. So this is for problem drinking symptoms. So here we see the log transform change, like baseline adjusted, and what we're seeing is a moderate effect size for the control, the intervention doing better than the control at 6 months. Again, it's persisting at 12 months, not quite as large, but still persisting at 18 months and at 24 months. So it does seem like these effects can be durable even up to 2 years. What about mental health? Like we talked about how these groups are vulnerable to particular mental health disorders. Can we see some changes in mental health and behavioral problems? This is for depression scores. This is for depression scores. I say NT. NT is just negative thinking. That's how we describe hopelessness to young people rather than using such a pejorative term as hopeless. So you can see the depression scores in the hopeless students are coming down from baseline to follow-up only in the intervention group and not in the control group. We see similar effects for the prevalence of panic attacks in the intervention group as compared to the control group. School avoidance, this was quite interesting. We looked at truancy, and we saw that the effects were particular to the AS group. We had kind of thought that they would be something we would see in the impulsives or the sensation-seeking kids who are off school for a thrill. But instead, we saw it was the AS kids, and we think they're missing school likely due to fear-mediated avoidance. And then in terms of acting out behaviors, we see a reduction in shoplifting in the impulsive kids who got the intervention. Then moving on to another randomized controlled trial that Dr. Conrad did in the UK, the Preventure trial. This was with a larger group of younger adolescents, again, starting younger, even before kids are necessarily starting substance use. And participants, again, were randomized to either receive a personality-targeted intervention or no intervention. And I should mention that randomization was at the school level. The outcome data were collected at 6, 12, 18, and 24 months post-intervention again, and again using the stringent intent to treat kind of analysis. So I've presented alcohol, mental health. What about other drugs? In fact, we do see effects on other drugs. This is results for illicit drug use. So these are the kids that got the intervention. These are the kids that didn't get the intervention on illicit drug use. So we see that growth, the natural growth. And then we're seeing reductions at 6 months that are, looks like they pop back up, but they still remain much lower than the kids who didn't get the intervention at 12, 18, and 24 months. So, skipping ahead here. So we see results for marijuana, for cocaine, and for other drugs. So this can show you, for example, for marijuana, we're seeing reductions in the intervention group compared to the control group. So delayed effects at 18 and 24 months. For cocaine, we're seeing reductions initially. Now this odds ratio means that there's about an 80% reduction. Okay, so we see that at 6 months, 12 months, 18 months, and 24 months. And for other drugs other than marijuana and cocaine, we're seeing reductions at 12, 18, and 24 months. So again, kind of a delayed, and it's about a 50% reduction. Can we prevent cannabis use? So a graduate student of mine did some analyses on the Preventure data to answer that question. And he used logistic models, first of all, in the high-risk group as a whole, so collapsed across personality factors, and he found a 33% reduction in cannabis use onset at 6 months, and a reduction in cannabis use frequency at 12 and 18 months. So initially, it seems to be delaying use, and then once kids are already using, it seems to be reducing the frequency at which they're using cannabis. What about when we look at the subgroup level, so with particular personality characteristics? It does show that the sensation seekers are the ones that are more likely to be using marijuana early, and the impulsive ones, once they get going, they use more frequently after onset has already begun. And in terms of so that's in the control groups, what about the intervention effects? And it really shows that it's the sensation seekers that get the best results from the intervention on their cannabis use. So 75% decrease in marijuana use onset in the sensation-seeking intervention group, and that effect is maintained over time. So it seems the sensation seekers are particularly vulnerable to using marijuana early, and interventions targeting that group are more effective at delaying onset and growth over time in comparison to the other personality traits. What about the intervention being delivered by teachers? And so in the Preventure trial, the difference was that we trained, Patricia's team trained teachers to put on the intervention. So these were either guidance counselors or teachers with particular interest, and they were given a very intensive 3-day training, and they were closely monitored and supervised in their delivery of cases. So they'd get feedback on videotape cases before they actually ran the groups. What you can see here is, I'm going to move over to the alcohol users at baseline. So this is the results for the Canadian trial, the Preventure trial, and then moving into the Preventure trial, and seeing if the effectiveness is lost when you deliver it by not by trained professionals. So remember the Canadian trial, we put that on with counselors from an addictions program locally. What happens when teachers deliver it. So the odds ratio, this is basically showing a percent reduction in alcohol use, in binge drinking for those that were using alcohol at baseline in the Canadian trial, about the same in the Preventure trial, so real replication there. But what you see is you really haven't lost much by going with teacher delivery. And the advantage of the teacher delivery is that the schools have then taken on the program themselves, and that can maybe help with maintaining the program over time. Also, number of needed to treat. I just wanted to point out that a lot of universal substance-based education in the schools, the number needed to treat, that means how many kids do you need to treat before you get one effective case. So here, this would be number of kids you need to treat before you get one reduction in binge drinking, one kid reducing their binge drinking. And this is showing anywhere from 5 to 6 kids need to be treated to get that one case reduced, whereas the typical universal intervention is anywhere from 13 to 30. So this intervention is much more effective in terms of number needed to treat statistics. So just to summarize here, Preventure with youth who are already drinking seems to increase abstinence and reduce binge drinking. When we apply it even earlier, it's delaying growth in adolescent drinking and binge drinking. The effects on alcohol problems, for example, seem to be durable at 2 years, and the effects extend to mental health outcomes. And it seems to prevent other substance misuse beyond alcohol, so for example, cannabis, cocaine, other illicit drugs. And recent directions. Right now, we're finishing up the Preventure program in Montreal. So that's the program's been put on in 32 schools in Montreal. So I'm a part of that. Patricia Conrad is back in Canada now, and we're doing another Canadian trial that we've labeled Preventure. So we're looking at the longer-term effects up to 5 years, and we're also looking at the cognitive impact. So there's been some evidence suggestive that early onset drinking and potentially cannabis use as well is associated with cognitive difficulties for youth. Now, there's a lot of debate on whether that's causal or not, or is it the kids that have these cognitive difficulties who get involved earlier with substance use. But assuming that there is some kind of causal relationship, you would think that if you delay onset of substance use through the Preventure program, that you might also prevent those kind of cognitive impacts. So that's one of the things we're looking at in the Preventure project. We've also been, while Tricia was in the UK, I've been doing some work on looking at whether the model holds in youth and specific challenging contexts. So we've done some work actually with, I should have credit Chris Weckerly here as well, Chris Musquash, Nancy Camo, Chris Weckerly, and myself with First Nations adolescents, validating that the model does hold in First Nations adolescents, even when there's so many other things that can be accounting for substance use, but even in that group, we're seeing validation of the model. And child welfare youth, so a former postdoctoral fellow, Amanda Hudson, and Chris Weckerly and myself have validated that model using the MAP data from child welfare involved youth in Ontario, and showing it also holds in that group. So we've been adapting the program for First Nations youth. I do have some data to show from that, but I really want to make sure that we have time for questions. So just very briefly, we have not a randomized controlled trial, but an initial test of the intervention where we culturally adapted it for First Nations youth and found reductions in drinking problems, as well as marijuana use. So very encouraging results, and hopefully with some money we might be able to test that in First Nations youth. So I think right now I'm going to open it up for questions to make sure we have time for that. So Doug, do you want to take some questions for me?
All right. Thank you very much for the great presentation. I mean, it's a great model and lots of great research to back and evidence to back up everything you presented here. So it's really fantastic. So as Sherry mentioned, it's your chance to ask a question or provide a comment if you'd like. The one question that came in was you were sort of talking a bit about it at the end here, was around sort of cultural relevance. They weren't specifically asking about First Nations youth, but more sort of immigrants, refugees, other sort of culturally homogenous communities within larger urban centers, perhaps. Just wondering how applicable the model was there, or if you had any evidence around that.
Yeah, I mean, we think now, we were just talking, I was just delivering with Tricia a training program for people wanting to use the intervention in Montreal last week. So we had people coming actually from around the world who were interested in the intervention. And so we've kind of developed a method. This is based on our work with the First Nations groups in how to adapt this intervention culturally. So what we do is we try to keep the program, the structure of the program, really consistent. However, spending time with the community involved and particularly interviewing kids from that cultural group on their experiences so that you can change the scenarios that are in the manual to really match to kids' experiences in that cultural group. Another thing we did with the First Nations was in spending time in this cultural exchange is we realized that their medicine wheel concept actually maps nicely onto cognitive behavioral, the cognitive behavioral model that we use, but we had to use different language to describe it within the medicine wheel. So the medicine wheel talks about, for example, relations between emotions and the way you think about the world, which is a very CBT kind of concept. But we put those things onto the medicine wheel and talked about it from the medicine wheel perspective rather than from CBT language to make it more relevant for that group. So potentially in doing the cultural exchange piece, you can learn some things of how you'd want to present the material slightly differently to make it more applicable. So far, when we've looked in other cultural groups, we have found that the model still holds, but I can't say universally that we've done it well enough to know that it would hold universally. We do know, for example, that the five-factor model of personality has been really validated throughout the world. So I would suspect that the model will, as long as we're getting at the constructs using the right language in the measure, that the model would hold cross-culturally.
All right, thank you for that. The other questions that were coming in, a couple of them were related to they're interested in the program and how they would go about implementing this. What would be their next steps if they were interested in sort of incorporating this into their school, et cetera?
Yeah, so we've been really working on this. This is the hardest part for academics, right? Is that we're rewarded for doing the next research project, not for the implementation. But we've been really trying to work out a good implementation model. And in fact, we have a grant that was reviewed well at CIHR, and we're hoping might make it through the next time, where we will be looking at different models for where the question is about the best way to get this out into the schools. In the short term, however, we are providing occasional training opportunities. So as I mentioned, we did last week, and actually I'll put up my email there for those that are interested. So Dr. Conrad and myself are making sure that we're offering the training in similar ways. And we offer either a 2-day training or a 3-day training, depending on people's background with CBT. So the one last week in Montreal was a 2-day workshop where people who already have CBT training are trained in the model. And then then there's the possibility of developing contracts for getting supervision in putting on the intervention. So that would be kind of another level of training. And we do have the manuals for sale, although we don't make them just readily available to people that don't have the training, because we're just trying to make sure that it's implemented correctly. So people that are interested could get in touch with me, because we do plan to, we don't have a date set, but we do plan to have other training sessions.
All right, that's good to hear. The next sort of question / comment that came in is saying, she says, I'm interested in seeing how this would work in an adolescent concurrent treatment program. The work around teaching teens about the personality risk factors seems to be such a key piece in targeted prevention within a treatment context. Is there any thought about adding treatment settings to the research?
That's a great question, and I've always been very interested in that. In fact, we're doing some work with that, on that very question in adults right now. So interestingly enough, we validated in people who are on methadone maintenance that personality still products substances that they are topping up with while on methadone. So, for example, the anxiety-sensitive people last 30 days while on methadone are more likely to be misusing anxiolytics. The hopeless individuals are more likely to be topping up with opiates, and the sensation seekers with stimulants and with cannabis. So we're working with the clinics right now to look to ways that we might adapt the program to make it useful for clients, and speaking with clients as well about the ways that they perceive we would need to adapt the interventions. But in terms of back to youth and concurrent disorders, I think it's a really nice match, but I just don't have any data yet to say that this would be a useful approach. My own thought is that probably we would need to make it a little bit longer rather than just the 2-session brief intervention format. I have done some work with the anxiety sensitivity piece, and for people that are more severely affected, making it an 8-session treatment. And we've had good success in delivering that at a distance to, 80% of the sample had full diagnoses, so, and some of them concurrent anxiety and substance use problems. So it really is an empirical question if you could achieve the same results with a more, with a clinical sample in 2 sessions, or whether you'd need to expand it a bit. But I think it has potential for use in that area.
All right, thank you very much for that. And with that, I think we don't have any more questions right now. There may be one last question that we could take if people are quickly typing away on their keyboards right now. We might be able to squeeze one more in. But while we're waiting for that, and maybe we'll take one in after this, but if there is the last one that comes in. But maybe we'll just go back to you, Dr. Stewart, just for, what are the key messages you'd like people to walk away with from this session with, just to reiterate, or anything that you'd like, any other messages you'd like to leave the audience with?
Maybe because I jumped over the work with the First Nations, maybe I just will show that data, because I think I can do it quite quickly. But so as I mentioned, we had validated the model in the First Nations adolescents with my former graduate student, Chris Musquash, who's now at Lakehead University. And we did an open trial. So this means that we didn't randomize kids to the interventions, but rather we identified high-risk kids, invited them to come, and our control group was the kids who met the criteria but didn't come. So it's not a good control group in terms of a scientific sense, because the concern, of course, would be that the kids who don't come are the more impaired ones, so we really don't know if the intervention would work for the more impaired children. However, interestingly enough, and we did the cultural adaptation that I mentioned to you, and we called it Namisink. It was done with 2 local First Nations communities of Mi'kmaq people here in Nova Scotia. And interestingly enough, what you'll see on all the figures is that the kids who chose not to come were less rather than worse off. They were lower on all the scores. So it's almost like the kids who needed to come are the ones that chose to come. So we got effects, for example, for drinking frequency in the experimental group, but not the control. So the kids who got the intervention, not the ones who didn't. For binge drinking, we got a trend. small sample size, but it looks like it's a meaningful effect. Alcohol problems. In fact, we brought them from the clinical range on average on the RAPI into the non-clinical range on the RAPI. So that's quite encouraging. But as you can see, the kids who didn't come didn't really have alcohol problems. And alcohol abstinence, so we had more kids that were stopping drinking in the 4 months after the intervention in the experimental group than the control group. And in terms of recent marijuana use, we don't see so much that the controls are, really low on that, but we did see an effect only in the experimental group, in terms of the kids that were using in the last 30 days. So some really encouraging results there, but we do need a full randomized control trial or something that at least is a bit more controlled, where you could do something like bring in communities. Like, there's concerns, obviously, if we've got good results in a randomized controlled trial, but maybe bringing on communities and collecting some data from the communities that haven't got it yet, and then going into those communities when we do have limited capacity anyway to provide the training. So there's different models we might be able to do to have a better design. And I just wanted to acknowledge all the people. Somebody's cut off at the bottom there. I didn't mean to do that, but definitely my long-term collaborator in this area, Patricia Conrad, who's really, done so much with the program during her time in the UK. And my former supervisor, Bob Peel, and Maurice Dangier, the late Maurice Dangier, who was one of the original conceivers of the work that led to the adolescent intervention. Chris Musquash at Lakehead, Trish Wojcik, who developed the substance use risk profile scale with us, Tib Mahu, my current graduate student who did the work on cannabis, and Marvin Crank, who did the longitudinal work looking at showing that these personality risk characteristics show escalations, are predictive of escalations in substance use over time and use. And there's many other people I haven't listed here. But anyway, thank you very much for the time today and for your interest. And
certainly our pleasure. It was a great presentation and a great way to finish it off, just adding that extra piece, or just a little sneak peek at the evidence from the adapting it to the First Nations community. So that was. I'm glad you added that.
This is very interesting. We might be able to also adapt it for the child welfare context as well. So that's another potential in the future.
All right, and with that, we are just about out of time, so I think we will wrap it up. We didn't have any last-minute questions come in, so I think we can wrap it up now. So thanks again for such a great presentation. It's often the whole issue of substance use and addiction and mental health it's something that our community, the children's hospitals and the acute care and the pediatric health center community struggles with, because it continues to impact the services delivered at hospitals and other centers, but the solutions are often not within the hospitals, in the education sectors, in the communities, et cetera. So it's great to hear this kind of research that's going on to help address these problems. So thank you very much for coming.
Thanks again for having me.
All right, we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's great when you can watch live, as your questions and comments really do enrich the discussion. But we did have a couple questions about parts that people had missed and recordings, etc. We do record these sessions and make them available after the fact on the Knowledge Exchange Network at www.ken.cafc.org. This is, in fact, our second last webinar for the season. We take a break over the summer. We do have one next week on June 28th. We will be introducing Child Bright, and we will be presenting an opportunity for you to get involved in their patient-oriented research network. We'll be joined by Dr. Annette Maneemer, along with Dr. Stephen Miller, Dr. Dan Goldwitz, Frank Gavin, and Dr. Keiko Shikako-Thomas, as they share an overview of the Child Bright network and how it is currently supported by patient-oriented research, patient-oriented training, and citizen engagement and knowledge translation programs. So that's going to be a very interesting session, and that will, as I mentioned, be our last session. We'll be taking a break for the months of July and August, and coming back, of course, in September. So some great stuff coming up next week, and then a nice break over the summer. So hopefully we'll see you next week. Bye.